So I have the pleasure of kicking off things today, and I'm going to be speaking to you guys on emerging therapies in fatty liver disease. So I have no disclosures. So let's start off just by talking about non-alcoholic fatty liver disease, also known as NAFLD. So I think, and seeing lots of familiar names in the audience, I know you guys are more than aware of the problem that is fatty liver disease and how prevalent it is in our society. Estimates have it where potentially at least a third, if not more, individuals in this country are afflicted with fatty liver disease. And we all know that it can have serious consequences to their health overall. And as a liver doc, we see the end stage of this, which we try to never get individuals to reach that point. And that's really what the fight is all about here. So again, when someone starts with a normal liver, ideally, and then we don't always know what drives it, but it's very strongly linked with insulin resistance. But they will start to get fat in the liver. We call that, and that's bland steatosis or NAFLD. And then what happens, and again, we don't quite know why. There's lots of different theories out there and lots of different pathways. But in some individuals, that fat starts causing inflammation. And that inflammation starts leading to potentially scarring of the liver. This inflammatory process and scarring is what we call NASH, so non-alcoholic steatohepatitis. And that's really the form that as a liver doc we worry about. To truly diagnose that, and we'll talk about that more today, requires a liver biopsy, but that doesn't make sense in all patients, so we do that in selective individuals. But really how to treat NASH and prevent the progression, as you can see here, to cirrhosis is really what this is all about. Now let's get a little bit of a background on these different terms we're going to be talking about today, just get everybody on the same page. So when we talk about fatty liver disease, stage is always important. And so this has to do with the fibrosis. And again, fibrosis is what portends problems from a liver standpoint. When we talk about early fibrosis, we're typically talking about stage 1 to 2. And then more advanced fibrosis is going to be where you get the bridging, stage 3, and then cirrhosis is stage 4. Another important thing to talk about, especially when we're talking about targets and medications, is the NASH activity. So NASH activity has to do with the 3 different factors when you look at the biopsy under the microscope, and it includes steatosis, ballooning, and then lobular inflammation. So those 3 things together are scored by the pathologist, and we get what's called a NAFLD activity score, if you guys ever see that term out there. I will say the NAFLD activity score is something that really came about and was utilized in really studies trying to look at targets histologically on what shows improvement and what are we looking at and what are we trying to have these medications help improve. And so studies will talk about improving the NAFLD activity score as well as resolving NASH. And resolving NASH really revolves around having these histologic parameters improve. So I can't talk about fatty liver without talking about the primary management. What's really critical with fatty liver is that you address the metabolic problem. And so the focus and cornerstone of treatment really is always weight loss. And so there's a whole nother talk you can do just about effective weight loss strategies. So we're going to have some further talks today that we'll talk about other ways to try to get weight loss, because as we all know, it's extremely difficult to get sustained weight loss for patients for lots of different reasons. The weight loss goal with fatty liver, where we see improvement in all those parameters I've already been talking about, is around 10%. In one small study in 2017, when they had patients reach this weight loss goal of 10% and had repeat biopsies, 90% resolution of NASH, 81% fibrosis regression, and even 100% steatosis regression. So that seems amazing. Why do we need other therapies? Well, the problem is weight loss is challenging, as I mentioned. Only 10% of patients in that particular study reached that goal of greater than 10%. So we need other ways to help our patients and help prevent progression. Now, one thing to know, there are no FDA-approved treatments for non-alcoholic steatohepatitis or fatty liver. So again, looking at this spectrum, when they have bland steatosis without NASH, likely the main thing we need to do, or what we really feel is needed, is these lifestyle modifications and things to help with the metabolic issues, because that's really where the health issues really come up in those patients. Once somebody has NASH, non-alcoholic steatohepatitis, that's where you're going to want to think about pharmacologic therapy potentially, and especially in individuals that have more advanced scarring. And then, of course, because we're trying to prevent them from ending up with cirrhosis. Now, just a brief summary. So what's out there currently? Again, there's nothing that's been approved by the FDA specifically for NAFLD and NASH, but there's a couple things that actually are mentioned in the guidelines and have some role. There's always caveats, though, with everything in life, of course. So one thing to mention, vitamin E. So mechanism of vitamin E, as you guys are probably aware, is addressing the oxidative stress that seems to drive fatty liver as well. There was a pivotal trial, the Pivens trial from 2010 that looked at both vitamin E and pioglitazone. So there was potential benefit. So histologically, when they looked at repeat biopsies, there was an improvement in the NAFLD activity score. So those parameters under the microscope did look better, but it didn't show an improvement in fibrosis. And when you look at what shows clinical outcome problems, it's when there's progressive fibrosis. So hard to get too excited about these, but they are mentioned in the guidelines and might be of benefit in selective groups. One big caveat is that vitamin E was really only studied in non-diabetics in a real close way, and also it was non-cirrhotics. And vitamin E, there have been some large studies that looked at and show some concern for some increased mortality risk overall with high dose. There's also some signal for prostate cancer risk, hemorrhagic stroke. So it's not completely benign. So we have to really have these risk-benefit discussions with patients for if they might be, that might be what's right for them. The guidelines mention that it can be considered in biopsy-proven NASH in non-diabetics. So that's where you might consider that. Pioglitazone also again mentioned in the, so similar benefits were seen in trials. There was also a trial with pioglitazone that looked at diabetics as well. So you can think of this in diabetics or non-diabetics. And I think this is typically something that would be more embraced by endocrinologists or a diabetologist that might be able to use this in an individual they know has NASH as well. And again, biopsy proven is what the guidelines mention. So these are both limited though in their efficacy again, and there's also concern for safety as I mentioned. So we need something better. So this is the crux of my talk, really talking about these emerging treatments that are out there. And this slide busy, but it's supposed to be busy because that's actually, it's a busy field and there's so much hard work going into this. There's, as you can see here, just a myriad of medications being looked at across the whole spectrum of NAFLD and NASH. So you can see this looks at the whole spectrum of, this is not a talk that's really going to go into depth on the pathophysiology, but you can see that there's issues across the whole spectrum, all the way from the insulin resistance that starts things to the lipotoxicity that then triggers this inflammation and immune reactivation, and then leading to apoptosis, and then ultimately this fibrosis with this dense collagen deposition. So unfortunately, there's always these things that we're so excited that something's coming up, but then we find out that there's been, it really doesn't come to fruition. So we have to just keep trying. So a few medications that were out there we were all really excited about, including simtuzumab, selonsertib, you can see those here. Unfortunately, further data wasn't as promising, and so those were discontinued. But there are still several promising things out there. So things that it's hard to know if they'll be the one that really comes to fruition. Ultimately, what's likely going to need to happen is that we'll have to have multiple medications addressing multiple targets to really address the whole spectrum of the disease. So you can see here in green, there's several agents, and we're going to go over some more of these in depth, and you can see their just general mechanism of action there as well across the spectrum. Now let's talk some more about these medications across the spectrum. One of them, the agent that you guys might have heard some about because there's been some promising phase 2 for all of these, and thus they are proceeding into phase 3 trials. So one thing I want to mention before I delve into this chart, as the study and look into these medications has evolved, the FDA has actually come out with 2 histologic endpoints that they've really defined as being what is likely to predict clinical benefit. One of those is seeing resolution of NASH on biopsy with no worsening of fibrosis. And the other big histologic endpoint is this improvement in fibrosis, typically 1 stage or greater from that stage from 0 to 4 that I showed you earlier, with no worsening of NASH. So those are the 2 big endpoints that you'll see. Some of the studies are set up to address one of these, and then some are actually looking at both as well. So first agent we'll talk about briefly, Sinciboroc. This is a CCR2/5 antagonist. And if you remember from that prior busy slide I had, this is addressing more fibrotic pathways, so farther on the right of that spectrum. The trial is the Aurora trial. You can see quite a large number of patients are involved in that trial. They're looking at the stage of fibrosis improvement with no NASH worsening. Another one that's being looked at, elfibranor. You guys might have heard of some of the promising results from that trial as well. This is a PPAR alpha delta agonist, the Resolve It trial. And this is looking at resolution of NASH with no fibrosis worsening. One that we're going to talk about a little further is the obeticholic acid, FXR agonist. This is Regenerate and Reverse trial. So this is actually looking at the, Regenerate is going to be looking at your non-cirrhotic, and the Reverse is the cirrhotic arm. And so we will hear more about the Regenerate trial. There was exciting interim analysis that was published in 2019. And so we'll delve into that further. So then moving on to resmetirom. So this is a thyroid hormone receptor beta agonist. This is looking for resolution of NASH, and the phase 2 trials had some promising improvement in steatosis with this as well. And then aramcol is an SCD1 inhibitor, which is early in the pathways looking at insulin resistance. This is the ARMOR trial. And again, this is actually looking both to see if it's improving fibrosis and also assessing for resolution of NASH. So let's delve into obeticholic acid. So obeticholic acid, this is an FXR receptor agonist. The farnesoid X receptors. So this is a nuclear hormone receptor. It's mainly expressed in liver, intestine, kidney, adipose tissue, immune cells. So you're probably thinking to yourself, that's a lot of tissue. Well, a lot of things are involved in fatty liver. So that's why it's promising, because it targets lots of different tissues that are related in the pathogenesis. It also has lots of target genes. You all may know about obeticholic acid because it actually is FDA approved for a different type of liver disease, primary biliary cholangitis. And we've been using it in that patient population for a few years now. It does have a target of bile acid synthesis, thus it's utilized in that cholestatic liver disease, but downstream pathways involve glucose metabolism, liponeogenesis, and so it is a lot of promising results. So you can see here, you got your little binding of obeticholic acid, pops on to the FXR receptor, and then downstream things happen all across the spectrum, trying to really target all these different things that are involved in fatty liver disease. So the Regenerate trial. So again, this was published in late 2019 in the Lancet, and this was a planned interim analysis of this phase 3 trial. So it was a randomized double-blind, and these individuals were on obeticholic acid. They enrolled in the Regenerate. It was the enrollment was for stage 1 all the way to 3, but the plan was for looking at the stage 2 to 3 fibrosis patients. So that's who they actually looked at once they reached this 18-month biopsy endpoint. And then they looked at their 2 primary endpoints. And so again, they were looking at both of these primary endpoints because these are felt by the FDA to really be the clinically significant endpoints histologically. And so again, fibrosis improvement and then NASH resolution. So the design of the study, it was a 1-to-1-to-1 randomization, so the placebo, and then they looked at 2 different dosings, the 10 milligram dosing and then the 25 milligram dosing. So the population they looked at, you can see here, this was again the stage 2 and 3 patients that made it to the 18-month endpoint when they got to about 750 patients, is what they were looking for. And you can see the different parameters here. One thing to note, again, they had the stage 2 to 3, fairly active NAFLD activity score with 70-ish% being greater than 6 points on that scale that I showed you. And fair amount of diabetics, at least over half the patients were diabetic and they had multiple other of the metabolic complications that we know go hand in hand with fatty liver disease. So a very representative population of the patients we really worry about. So then the results, very exciting. They did meet one of their, the 2 primary endpoints. And what was very exciting is that they did show this improvement in fibrosis of one stage greater that was significantly greater. So the placebo had 12% of patients had improvement, compared with the higher dose of the beta-cholic acid was 23%. So here, this is just kind of zooming in further in details on these different parameters. So you can see there the significant p-value for that upper intention to treat population of the 12 of the green placebo versus the red 23% for the higher dose. And then you can see the per protocol had even a slightly higher total difference there. On the bottom is there showing that they did not meet the NASH resolution with no worsening of fibrosis. So I thought this was a very interesting graph that they had also in this paper, because it's really encouraging as we're just looking for things that are going to help resolve fibrosis in these patients. You can see there that overall this whole shift in the pattern of fibrosis. That bottom bar there, that green, is showing what we expect in the natural history of fatty liver disease, that some are going to worsen, some are going to get better over that time period. So that fits what would be expected with the placebo. You can see that whole bar shifts as the people are able to tolerate the 25 milligrams. Another exciting thing is that they had 10% of individuals on the 25 milligram dose actually have a 10% 10% had greater than 2 stages improvement in fibrosis. This is just quickly showing that the ALT, AST also improved on therapy, as well as the GGT. Now let's get into always the caveats. So there were a few things that are going to potentially affect the tolerability of this. So the biggest thing you'll see there, 51% of patients on a beta-cholic acid, the higher dose, had significant, had mild to moderate pruritus. So most could tolerate it, but having somebody on something that's going to make them itch is going to be a problem in real world use. You will notice that 20% on the placebo also had pruritus. So potentially just asking somebody if they're itching might make them itch. So something to note though. Another thing, there wasn't an absolute difference that was noted, but just noting that gallstone related events, again, remember this has bile acid pathways. There were 19 episodes of gallstone related events in the high dose. It wasn't, again, significant, but that's something that will need to be followed as there's further data. Another thing that's important to note, there is a known effect on lipid profile. This patient population is high risk for cardiovascular events, so we don't like when their LDL goes up, but it does on a beta-cholic acid. Of note, when they put people on a statin, that did improve back to the baseline, and that was maintained while they're in treatment. So you got to get them on a second medication potentially, which is not ideal, but a lot of these patients benefit from being on a statin anyways. So take-homes from this beta-cholic acid interim analysis. So the first positive phase 3 trial in NASH with the primary endpoint of actually improving fibrosis, so very exciting. There was this mild to moderate pruritus, most common adverse event with a dose-dependent incidence. Treatment was also associated with these lipid changes, but was alleviated by statin therapy. So this is all very exciting, and it still is. This was submitted to the FDA, but to try to get early approval, given the known need for this. But the response from the FDA was that it needs more data. You can read the details of the true FDA response there, but it's promising, they basically said, but we need more data to show that the efficacy is worth the potential risks. And so they did recommend that the trial continue, and they'll further address once further data is available. So in summary, the cornerstone of treatment of NAFLD and NASH remains sustained weight loss of greater than 10% as your goal. There are no FDA-approved pharmacologic treatments for NAFLD and NASH. Vitamin E and pioglitazone can be considered in biopsy-proven NASH, but the data does not suggest a significant improvement in fibrosis. NASH with advanced fibrosis stage 3 to 4, I would say, is a very unmet need, with many pharmacologic targets under investigation. A lot of people working very hard on that busy, crazy slide. Multiple promising targets, different pathways are ongoing in these phase 3 trials So hopefully when I'm given a talk in the next couple of years, or one of my colleagues is, we'll have even more exciting results for you guys. So, all right, so that's my thoughts on fatty liver. Again, we will be talking more on our, as we proceed, and we'll save questions for the end.